Welcome to All Things Cardio-Oncology. This is the podcast of the International Cardio-Oncology Society. My name is Steve Caselli. I'm the Executive Director of ICOS. And I want to welcome my co-hosts today, Dr. Daniel Lenihan, who is in the St. Louis area, and Dr. Arjun Ghosh in the UK. So Arjun, welcome.
Thanks so much, Steve. Really happy to be here for this episode, which is promising to be excellent.
And welcome, Dan.
Thanks again, Steve. And as always, these podcasts are quite interesting to me, and learning about what people are doing around the world to improve heart health in patients who either have cancer or have previously been treated is easily my favorite topic.
Great. We are so glad to have you. And I'm personally really excited about this episode today as well, because one of my first exposures to cardio-oncology was through a family friend of ours who at the age of 30 had to have a heart transplant. And I didn't realize it at the time, but he was actually a childhood cancer survivor. And it was his cancer therapy as a child that actually led to his heart failure. So my personal early exposure to cardio-oncology was through pediatric cardio-oncology. And today we have the privilege of hearing from two of our key leaders in our Pediatric Cardio-Oncology working group. Veronica Santos is in Brazil, and she's the chair of that working group, and Neha Bansal is the co-chair of this group. And so I want to welcome both of you to our show today. Veronica, please say hello and introduce yourself a little bit.
Hi, Steve, Dr. Lenihan, Arjun, Neha. Thank you very much for this opportunity. Congratulations for ICOS providing this podcast that allows so many people around the world understand and recognize the importance of cardio-oncology. I'm very thankful for this opportunity and to be part of the pediatric cardio-oncology team. Thank you so much. I'm a pediatric cardiologist in São Paulo, an echocardiographer with special interest in survivorship programs, but also looking for children before and during their treatment. So thank you so much.
Great. Thanks for being with us. And Neha, tell us a little bit about you and your work.
Hi, thank you so much for the invitation. I'm really honored to be here. My name is Neha Bansal. I'm a pediatric heart failure transplant cardiologist at Montefiore Hospital in New York City. I have a special interest in survivorship as well, like Veronica, and I also run the cardio-oncology program here at Children's Hospital at Montefiore. So really excited to be here. Thank you.
Great, so good to have you. I'm going to turn it over to Arjun and Dan, who have some further questions for you.
Great, thanks so much, Steve. So I'm going to be asking a question. Maybe I'll put this to you first, Veronica, and then maybe Neha, if we could get your take. Our listenership is a mix of adult cardio-oncologists and pediatric cardio-oncologists, but maybe some of the adult cardio-oncologists have not that much exposure to the pediatric cardio-oncology domain. So if you could just tell us a little bit more about, pediatric cardio-oncology, what it involves, and how it's different from adult cardio-oncology. Veronica, please.
Oh, yeah, thanks. First of all, I'd like to say that childhood cancers represents around 1 to 4% of all cancers. When we add pediatric and adult cancers, we are a very small number of population, but they are very important, of course. The childhood cancers have been diagnosed earlier around the world, providing much more chances of cure and increasing in survival rates from around 60% in the mid-70s, and nowadays more than 80% of chances of cure and good survival. Talk about pediatric cancer has lost the taboo, and pediatricians and parents, they are able to approach the subject more easily, allowing early diagnosis, which promotes and provide a proper and efficient treatment. However, some treatments can cause multi-organ toxicities, as we are here to talk about, including the heart. And especially children, they have a high vulnerability to develop cardiovascular complications. That's what we call cardiotoxicity in so many different ways. And it's important to say that we do need to consider that young population has a long life expectancy along the years, and just cure cancer without a heart program, it's not very, very fair. So cure cancer with a good quality of life is our main goal. That's why we are here. Thank you.
Great. Neha, what are your thoughts?
Yeah, I think Veronica touched on the most important part about pediatric cardio-oncology is the fact that we have excellent survivorship rates in the current era. Like she said, 80% of our patients with cancer survive long-term, and which has increased leaps and bounds from the 50s and 60s. And so we are seeing patients who are surviving long-term. So at this point in time, if we look at statistics on these survivors, cardiovascular complications are actually the #1 non-oncologic cause of morbidity and mortality in these patients. And it's actually interesting that when you compare these patients, cardiac cancer survivors, cancer survivors to their siblings or age-matched controls, the rates of cardiac death are 8 to 10 times higher in these patients. And that has to do with the fact that these patients live longer and we just know them for a longer period of time. So I think it's very, very important to recognize these more long-term side effects of like cardiotoxicity in these patients. So I think that is a big difference from the adult cancer survivors, that they live a lot longer. And I think one of the biggest challenges in the field that we face as pediatricians is that as kids grow up, they move. And a lot of the times, unfortunately, they move across state borders, they move away, sometimes they move countries, and it's hard to keep track of them and follow them long term, which has been sort of the biggest challenge for us, as we sometimes have in all the pediatric cardiologists who are listening to this will recognize that one patient that just shows up in their ER that probably has this remote history of cancer and then just presents in florid heart failure, just not having had seen a cardiologist in decades. And so I think that is the biggest issue in pediatric cardio-oncology, because we see them these patients survive for so long. So we see side effects for a long period of time.
Sure. And we kind of have a good understanding, I guess, for adult cardio-oncology about the cancer types and the treatments and the cardiotoxicities. But if you could, maybe if I could start with you, Neha, I mean, what are the main cancers that you do see in children and the cardiotoxicities that you have to deal with?
Yeah, that's a great question. So we generally, the referrals that come to me as a cardiologist, not all cancers come to me. So I think the biggest ones that I see, we definitely see all the leukemia, so ALL, AML. We do see solid organ, solid tumor sarcomas, predominantly any cancers that require anthracyclines, which I think are the mainstay of a lot of chemotherapy in pediatrics. A lot of pediatric chemotherapy is anthracycline heavy, which is the #1 cardiotoxic agent that we follow patients for. And then we often also see patients with Hodgkin's lymphoma or non-Hodgkin's lymphoma, the ones that get some mediastinal radiation, so some side effects of radiation therapy we see there. So I think those are some of the very common cancers that we see. And then when it comes to chemotherapeutic agents, like I said, anthracyclines are our #1 chemotherapeutic agents to which we see long-term cardiotoxicity, which is where a lot of the research in pediatric cardio-oncology has been.
Sure. And Veronica, from your side, is it very similar? And in terms of the treatment that you offer the children, is it similar to adults in terms of ACE inhibitors, beta blockers? I mean, what are your feelings on that?
Oh, yes. Some things are quite similar. And it's very important, first of all, to consider that children usually begins the treatment with no comorbidities as adults usually have. And so we sometimes can admit that the complication, the cardiotoxicity is really unique and due to the cancer treatment, because the children usually comes with with a health system completely without no comorbidities and no past of pathologies that can provide a cardiovascular complication during the treatment. It's very important to understand it. The management is quite similar. And as Neha said, anthracyclines works in the majority of protocols in cancer, in childhood cancers. And of course, we also use tyrosine kinase inhibitors and other chemotherapy, chemotherapeutic agents and radiotherapy. But some of them, the complications are seen in the mid to the long term, in a long-term follow-up. During the acute cardiotoxicity usually is due to anthracyclines. And we are very aware to the subclinical diagnosis, especially with the use of biomarkers and a good imaging system, especially strain imaging during the echocardiography. And also another important subject is the arrhythmias. We can see arrhythmias during treatment with these children, and bradycardias and tachycardias, and we are very aware about the QTc interval that can be enlarged due to other drugs, and not only for the chemotherapy, but we are also making sure that everything is running all right. And another important issue is that children usually have infections, and it's very severe when we add infections and other complications with a cardiovascular complication hidden. So that's very important to the cardio-oncology, pediatric cardio-oncology, be close to hematology and the intensive care unit to be just in the right place in the right time to save this life. So that's what we usually work daily in our daily practice.
Okay.
Fantastic. Well, again, this is Dan Linehan, and just one of the biggest strengths about pediatric cardio-oncology is the extensive work, research that has been done about late effects. And honestly, if you look at the backbone of adult cardio-oncology, we really learned most of our important lessons from pediatric cancer survivors. So this is absolutely a cornerstone of our general understanding. So what can we as adult cardio-oncology people learn from the pediatric late effects survivorship programs that are now being developed? So Neha, I don't know what you think about that.
Yeah, I think the biggest challenge in pediatric cardio-oncology or pediatric oncology is numbers. We have such small numbers compared to adult oncology. So all our clinical trials or all our studies require extensive collaboration. Actually, any study in pediatrics does, even pediatric cardiology. So I think one of the biggest trends of all these different research studies, especially all the studies that came out of the late effects, from the Dana-Farber, a lot of them required a lot of collaboration with different institutions and, funding and trying to really follow the protocols and all the clinical oncology group, the children's oncology group. It's a true testament to collaboration. So I think collaboration and working together, forming protocols, standardizing care, I think those are certain things that definitely the pediatricians have learned over the years, which has come out of the need for numbers because all our studies, every single center sees such small number of patients. So collaboration is key. And so I think that is a huge thing, which I know adult cardio-oncology programs that are being set up are now working towards that. They're working towards standardizing care and working together and finding out ways to collaborate.
Yeah, that's a super important point. Wow, I think I couldn't agree with you more. I think if we can first learn our lesson from the pediatric cancer survivors about, how we monitor people over time, that these major institutions really sort of led the way in doing that. But just like you said, the idea of collaboration, where it really has to be meaningful collaboration. It can't just be, you talk to your friend periodically, it can't be that way. It has to be really integrated. That is a lesson that adult cardio-oncology needs to learn, that's for sure. So Veronica, what is your experience in Brazil? Is that different or the same, or what do you think?
No, it's growing and is quite the same, and we can understand that there is a need for a bridge between pediatrics and adult cardiologists in a time of the life of this patient, of his survivors, and so we work together. So there is a time that they need us to understand what's happening and how to deal with the complication in a late time, and we need them to understand and follow the patient with adult issues. We know that these survivors, they develop early signs of atherosclerosis, valvular diseases, and they are much more suitable for comorbidities in a young adult age. So it's very important, this bridge and this collaboration. We are having a very special attention nowadays for women who want to be pregnant. And they are survivors from cancer, childhood cancer. So we are very aware about the need of a close follow-up during the obstetrician follow-up, the prenatal tests. And so we are close to them. And so in fact, here in South America, women do want to be pregnant very young, and they still have this culture. And so we are in the counseling system, it's very important to be close to them. So it's part of our work here. So
sure. Well, and I also think that considerations about certain medications in a childbearing female is going to be significantly different than your average adult. So I think that these are very important topics. And it's especially in your view, Veronica, what are the other important topical research areas in pediatric cardio-oncology?
Now I think we are, as I said, these survivors have been paying attention here in Brazil. We are trying to spread this importance here in South America to look for them. But we do need a good registry. We do need to understand what are the late effects in the people who were treated during childhood here in this part of the world. So based on this, we want to recognize and plan the needs of each institution and educational needs. So we are in a very basic phase of the Pediatric Cardio-Oncology educational program, differently from the adults who the translational science and everything is growing faster. So pediatrics is growing a little bit slow, and we always take an example, the adult experience, to understand what's happening here with the pediatric ones.
Fantastic. And Neha, what would you say is, sort of your important topics that you either think your field would want to pursue or you personally have identified?
Yeah, I think what Veronica touched upon, like the fact that pediatric cardio-oncology, we're still working on recognizing the best way for cardiovascular optimization in our survivors, or even like risk stratification for our survivors. I think the Children's Oncology Group has a great, they have some guidelines available, but there's still guidelines. There's no evidence-based guidelines yet for us per se to follow these survivors long term, which is probably the biggest challenge worldwide, I would say, even for adult cardiologists, like how to follow these survivors long term. All the guidelines, there's lots of guidelines out there, but just to find harmonization between those guidelines and maybe back it up with some evidence would be fantastic. So I think that would be the key for risk stratification. And then recently, I think there's been a lot of interest in genetic predisposition for these long-term cardiotoxicities, which I think has been a very exciting field. Can we tailor chemotherapy for some of our patients, based on their genetic predisposition? That would be like something long-term. If we could do that, would be very exciting. I think those are some of the key things that I think would change the future of pediatric cardio-oncology.
There is another, if you permit, another issue that has paying attention is the long-term effects of cardioprotection. We all know that some primary cardioprotectant agents, such as dexazoxane, is more in the majority of times they are used in children. And so with good results, we know, as Dana-Farber studies and so other ones, Dr. Lipschutz is one of the biggest persons who studied dexazoxane. And the late effects of this cardioprotection in a long-term issue that we really want to understand. And at the same time, carvedilol is very, very used here around the world. And so we do need to understand and recognize if it's really protecting in a long term these patients. So it's part of the interest in research in our area too.
So that's really great to hear, Veronica and Neha, that there's lots and lots of different, and quite varied research topics that are quite, active, and lots of evidence that we need to find out and grow the field, really. And one of the aims of our podcast is really to attract trainees in the field to the area of, pediatric cardio-oncology and the other topics that we talk about. So as a pediatric trainee, how can they train in pediatric cardio-oncology? What's the best pathway? And Veronica, maybe if I could start with you.
Oh, yes. First of all, usually, the people who is a trainee in pediatrics who has interest in the oncology and cardiology issues, they spend some time with the teams, with specialist team. But to be a proper cardio-oncology, I think that pediatric cardiology is the most important area to be advanced in the third, in the fourth year of training. Of course, imaging is an important subject that needs to be close to the clinician here. And because we don't have the possibility to really understand and really make a real diagnosis without an image, a good imaging in our hands. So it's very interesting. But so answering your question, pediatric cardiology, it's the main train that must be developed, and we are expecting to develop and attract much more cardiologists to this area.
Great. Neha, what was your experience in training in pediatric cardio-oncology, and how widespread are the opportunities in the US?
That's a great question. So unfortunately, there's no set path to cardio-oncology fellowship in pediatrics like it is there in the adults. The way I got exposed to cardio-oncology was because Dr. Steve Lipschutz was the chair of pediatrics where I was. And so it was very interesting how I got exposed to cardio-oncology because of his experience. However, there's lots of people across the country who have a lot of interest. Now, like Veronica said, there's some imagers who are interested in cardio-oncology, and then a large portion of pediatric cardiologists who are heart failure or transplant cardiologists like me are also interested in cardio-oncology. So I think it emanates from a place of interest. There is unfortunately no set training program that is out there. And I think a lot of people are learning this kind of on the job a little bit, and how they work with different people and partnering with their oncology team. And I think those are key ways to collaborate with different specialties within either cardiology and oncology and build a program together. That's how a lot of cardio-oncology services across the US, to my understanding, are building.
Okay, so that really very nicely leads on to my next question. If your area doesn't have a cardio-oncology service, how is what is the best way to try and develop a pediatric cardio-oncology service? And maybe if you could just tell us about what your day-to-day job entails.
Right. So when I joined at Montefiore, we did not have a pediatric cardio-oncology service per se. So I worked very closely with our oncology colleagues, and there is a REACT clinic, which stands for Reassessment and Evaluation After Cancer Treatment, which is short for survivorship clinic. And so I worked with the oncologist who runs the survivorship clinic in the oncology division. And there is definitely a need. Every oncologist welcomed the idea of having a cardiology partner on their team. And so we formed a clinic, cardio-oncology clinic, which worked in collaboration with the REACT clinic. So all the survivors who were coming to the REACT clinic who needed to see a cardiologist, I would kind of see them the same day. So it would run once a month. That's how we worked our outpatient clinics. For inpatients, I sort of would do consults on any newly diagnosed pediatric cancers who we know would receive either radiation therapy or high-dose chemotherapy. So a high-risk patient for long-term cardiotoxicity effects. I would go and talk to the families, go and explain them what kind of chemotherapy they're going to get, and with the oncologist, obviously, and then would talk to them about the long-term effects of that chemotherapy. So that's how our inpatient consult sort of teams worked. However, it requires a lot of collaboration, as you can imagine, with your oncology colleagues, because you would get consults only if you would have to work with them and they would call on you. And I think that our oncology colleagues are very excited to have someone interested and work with them. So I feel like if you just reached out, if you wanted to grow a program and develop a program, if you just reached out to your oncology colleagues that you have an interest and you would want to work with them, I'm sure that you can form a program together.
Great. And Veronica, is that your experience also in how to get a program, off the ground? And, what is your day-to-day job like?
Yes. The beginning was very hard. Nowadays, things are getting easier because we are always trying to make understandable and try to translate the cardiology for hematologists and oncologists and make them understand there needs to be a team. So nowadays, especially young doctors in hematologists and oncologists, they are much more close to us. And nowadays we have an interesting into hospital and outpatients clinic. And so we have the evaluation, the cardiology evaluation before each treatment. We understand and we discuss the design of the protocol and create the follow-up during this treatment of each patient. There is an important issue here that we need to say. It's very important to work together with the multidisciplinary team. So when we are talking about a good protocol, a good program, we need a good nurse close to us, a good manager of this protocol. And the nurses are wonderful for that. So other persons from the multidisciplinary team, of course, nutrition, psychology, physiotherapy, but nursing is the clue. So we know that they are very important for the success of this program. And as Neha said, they are very excited and being very interested to create protocols. And here in Brazil and South America, we are trying to make them much more excited every time that we talk in meetings, and every meeting. It's very important. Oncology meetings, cardiology meetings, pediatric meetings, they need to understand and know that we are here and that pediatric cardio-oncology really exists. It's not a dream, it's a real life. So we are working hard for it, but nowadays things are getting much more easier than in the past.
I wonder what you think is, what is the best way that we can continue to grow pediatric cardio-oncology? And I think by the fact that you guys are doing this podcast, I think that's a big step. But, there probably are other strategies. What do you think we should be doing there? So Neha, I don't know if you want to take that one first.
Sure. Thank you so much. So I think that, like I had alluded before, collaboration is key. Our numbers are very small at every single institution. So I think working together with different institutions and even countries, which is where ICOS probably comes into play. I think that collaborating across the countries, trying to find the numbers to work together for finding the best way to risk stratify these survivors, and then to work on maybe clinical trials. I mean, it's a dream to do pediatric clinical trials, and find best way to optimize their cardiovascular health long term. Funding has always been an issue for pediatric trials, unfortunately, given the low numbers. Successful trials are always hard to come by in pediatrics, given the low numbers, smaller sample size. We often get marred by negative trials because of very low death rate in pediatrics. So at any outcome measures are very, the rates are very low. So our trials often turn out to be negative. But I think if we can find novel biomarkers, which is where a lot of the research is going into, finding ways to optimize the long-term heart health of these survivors, I think that is the way to grow forward. So I think working together, finding ways to stratify and then treat these survivors together. I think so. Collaboration is the key to move the field forward.
Super. I guess that's like, basic advice when you're looking to buy or sell a house. You say location, location, location. So I guess we'll just have to say that from now on our podcast, collaboration, collaboration, collaboration. So
sounds perfect.
Yeah. So Veronica, what do you think in Brazil or beyond? What can we do to grow this field?
Yes, thanks, Dr. Linehan. As Neha said, collaboration is the magic word. And now our pediatric working group is working with a survey that's being sent to a lot of colleagues. And perhaps here we can give them a link to be part of the survey. So our intention is to recognize where they are, who they are, what their needs in pediatric cardio-oncology around the world, around the countries that collaborate with ICOS especially. And the other magic word is educational programs, and always remembering during meetings and talk to to people, make ordinary people understand and perhaps remember their doctors that the heart is there and the heart can be damaged during the treatment. And so it's a hard work to be close to everyone, but I think there are so many different ways to get close and improve and grow the field. And multicentric trials, of course, it will be the dream come true to establish really the reality of pediatric world in this kind of issue. Thank you
Yes.
so much.
Yeah, fantastic. And Neha, part of what you mentioned before about that there wasn't an established guideline, at least for pediatric cardio-oncology or aspects of it, and that is true. But I will have to give a little bit of plug to our colleagues at the European Society of Cardiology, who are developing a guideline document for cardio-oncology in general. And of course, they're focused on adults, but they actually have at least one whole section on cancer survivorship. And it is, I've seen it, I've seen the drafts of it, and I think it's going to be really good. And it will at least push the field forward some. Obviously, I think having more international input into how we do our studies better or how we treat these patients better, that's always needed. So I think it is exciting that these guidelines should come out in the August, September timeframe this year. And I would encourage you guys to take a careful look at the survivorship piece of those.
Absolutely. That's fantastic to hear.
Yeah.
I think the Children's Oncology Group definitely puts out some guidelines. And I think the what I was alluding to is the fact that these guidelines are mostly expert consensus, not so much evidence-based, which is what is needed to, I think, move the field really, really forward if we could get them with the help of registries and clinical trials. So really,
I mean, it's always much better if we have actual data to go through and find the strengths and weaknesses. And partially to that end, Veronica and Neha both have mentioned, about deserzoxane, and as a cardioprotectant, it's really the only truly effective primary prevention of cardiotoxicity, and the place and where it is really, found a benefit is in kids, but in the adult world, it kind of got thrown by the wayside, and we keep trying to pull it back onto the road here. But I do think that we can learn a lot from the pediatric cardio-oncology services about using deserzoxane in high-risk patients in particular. And so I think we have learned a lot in the past from our pediatric colleagues, and I think we need to continue to do that. And the whole survivorship piece really is, all of our basic information came from there. And then as I just mentioned about the deserzoxane story, I think that is a drug that thankfully has not gone away, but it sure has been hidden for a long time. So hopefully we can pull it back out again. But I would really want to thank both of you for joining in. This has been fantastic. And as I thought before we started, that I would learn a lot today. So I can say that I did. So Arjun, I don't know if you have some final thoughts too.
Yeah, I mean, I have to say that I've really enjoyed this, and exactly like you, Dan, I really have learned a lot, and I'm sure that this was a very useful podcast for our listeners.
Thank you so much.
Thank you so much.
Thank you for joining us today. If you would like more information about ICOS, go to ic-os.org, where you can learn more about all our activities, including our weekly webinars, our board certification exam, and our Centers of Excellence certification. Thanks again for joining us, where we are taking survival to heart.